as part of a larger project that the university was awarded by CAPES that will end now in October. This is an activity that simultaneously is part of the program to celebrate the 50th anniversary of the post-graduation in collective health of the Institute of Social Medicine, a beautiful logo of celebration. And we will have today the pleasure of receiving Professor Niru Gupta. Niru is a long-lasting friend. We worked together in the World Health Organization in 2002, 2004 maybe. So maybe in 2004 or 2005, I don't remember exactly. So in the beginning of the 2000s, she has a vast experience. She's a demographist and in statistics. She has the experience of working in the World Bank, and she was part of the team that coordinated the analysis of the health workforce, along with other colleagues from Senegal, Sudan, and Switzerland. And from that point on, she went back to Canada and finally she established in the University of New Brunswick in the Department of Sociology. And she has been producing research in the area of the health task force using quantitative and qualitative methods and using this methodology. And as part of the research that we coordinate in the Institute, my colleagues and I, and Fabiano, who is the head of the planning, Décio Santiago from the engineering college, and our colleagues from the nursing department. And we coordinated a project of analysis of demography, and we did a proposal to bring Neuro here to participate in the discussions with us with the projects, and this is already happening since Monday, since yesterday, and to share with us a little bit of her experience to use administrative data for demographic studies and the nursing workforce in Canada. And this can also help us bring insights on how we develop the project. And besides this presentation, we are making an analysis with her with all the database that we managed to obtain. On Friday morning, she will be in the nursing college here in the university to discuss a few projects that the researchers have and to debate collaboration in the long run and the short run between UERJ and the University of New Brunswick. So I really want to thank Nero. She understands a little bit of Portuguese, more than she claims to understand. But I want to thank her for being here, and let's hope her lecture can result in reflections and help us discuss more. So, Nero, please. Muito obrigada. Muito obrigada ao Instituto pela honra desse convite, principalmente na celebração de 50 anos
Social I'm very pleased to share some lessons learned and hopefully engage in a conversation on how we can work together to help strengthen the evidence base on the nursing workforce within the context of global health workforce strengthening. As Dr. Dalpos mentioned, I'm a professor of sociology at the University of New Brunswick in Canada. And while our countries may be divided by the equator, we share many characteristics, I believe, challenges in terms of strengthening nursing, training, recruitment, and retention, particularly in the post-pandemic period. We share a vast physical geography, our two countries. We share We share a rich and diverse population, and we share a thirst for knowledge and an evidence base that we hope together we can build stronger and stronger. We also share many challenges in terms of how our nursing and healthcare workforce data sets are siloed, underused, and just beginning as researchers, as policymakers, to start testing the limits of what we can learn from the data to build a more equitable healthcare workforce and ultimately equitable societies. This work, as we share our knowledge, is also strengthening the international frameworks such as the Sustainable Development Goals, interconnecting different aspects of social health, well-being, and economic justice. The Sustainable Development Goals are getting closer to the global deadlines. Only 6 years left before we have collectively committed to end extreme poverty, to ensure good health and well-being for all populations. And that entails the increase of the recruitment, development, retention, and training of healthcare workers. Better gender equality. Healthcare is itself a highly gendered healthcare workforce, and yet we know very little about how gender impacts those very aspects of training, development, strengthening, and retention of nurses and other healthcare providers. Reducing inequalities inherent in the Sustainable Development Goals is the ideal of empowering and promoting economic inclusion for all, including reducing gender wage inequalities. And yet, research how that affects healthcare workers and nurses in particular, a heavily feminine occupation, is much less prevalent compared to other areas of gender-related research and workforce research. And strong institutions. And that entails not just using data, but transparently disseminating data and evidence, not just among researchers, but so that people are better empowered, communities hold our decision makers accountable. So if you'll indulge me, I'll share some examples, lessons learned of different projects that we've been undergoing in the Canadian context that I think share commonalities, both in terms of ways forward in using data and some of the partnerships that we can potentially leverage to help bring these collective knowledge together. So we do know in terms of the nursing workforce specifically, 29 million strong around the world, and yet heavily feminized as well. Nurses represent nearly half of clinical care providers, and yet are less researched compared to physicians for a variety of reasons that I will speak to in a moment in terms of some of the underlying social theories of that. We do know that the pandemic, the COVID-19 pandemic, exposed deep challenges to strengthening the nursing pipeline in Canada, in Brazil, around the world. And so we need more evidence, data, and accountability to help bring together these research challenges where, in particular, nurses themselves are a very diverse population, not just in terms of being heavily feminized, but the definition of who is a nurse itself varies within and across countries. And so understanding the deep-rooted, not just scopes of practice, but how the data can speak to some or whole of the nursing workforce also can be a challenge, particularly if we're looking at developing comparative studies within and across jurisdictions and over time. And again, even though an estimated 90% of the global health nursing workforce in particular are women, there is much less research on gender and health workforce, particularly when we compare it to other domains of patient-oriented health research. So this is an area that I think we also share a common thirst for better evidence. So what do we know? Most of the global estimates suggest that around 90% of the nursing workforce are women. That, of course, will vary depending on a country context, the socio-political background. But in Canada, it is estimated that about 90% of nurses are women. That's an even higher concentration of women than other healthcare occupations combined. We know that strengthening and empowering women in the health labor market is likely to have multiplicative beneficial effects, strengthening overall society's development and overall economic empowerment. And yet there are tremendous challenges facing women in the health workforce. In its landmark 2019 report, the World Health Organization identified 4 particular domains where the evidence and policy levers and guidance are particularly deficient. And those are in terms of what are the barriers and facilitators to occupational segregation, the predominance of one gender in a particular occupation versus another. Decent work, and in this, women nurses face particular challenges, including harassment, sexual harassment, violence, that are not necessarily shared to the same extent among male nurses. Pay gaps, and we have some preliminary evidence of that in Canada, not just across occupations, but even within nursing itself, and leadership. We have also started demonstrating some of the evidence around the gender gap in leadership. And it can be particularly challenging because oftentimes when we look around the room, we might see many women. If I look around the room here, I do see many women. But does that mean that we have true gender equality in leadership? And if not, or if we argue yes, how do we know? And lastly, even studying gender issues oftentimes is considered a political decision rather than a research decision. There are increasing body of evidence, for example, that there is a bias against research focusing on gender-based research, considered a political decision rather than a neutral scientific evidence base. And so we have many hills to climb as women researchers, as women leaders in nursing, particularly of highly feminized occupation, in terms of getting the research out there, dismantling structures that may hinder the publication of research on the nursing workforce, and even overcoming subtle resistance to admitting that gender is itself problematic to advancing leadership in the nursing workforce. So in particular, we know relatively little about how women contribute to the social and scientific development of communities. We know less on nursing than we do, for instance, on the levers that strengthen the recruitment and retention and remuneration of physicians. And part of this is theorized, at least, to be rooted in some of the historical tendencies where nurses were seen to support men, to support the physician, rather than an integral component of healthcare delivery of themselves. And so the societal devaluation of women's work, of caring work, translates and persists into unequal pay structures, leadership opportunities, positions. And that is persisting even as more and more women move into traditionally male-dominated professions such as medicine, dentistry, psychology. Even in those positions that do tend to be women-dominated, such as nursing, we have found increasing evidence of a glass escalator, a metaphor for men being propelled upwards in their career at a faster pace than women, more likely to receive promotions, leadership opportunities, professional development opportunities, and higher pay than women in the same profession. But the very notion of a profession, of a sector like healthcare, is itself a social construct. And in patient-oriented research, we're increasingly understanding that the healthcare system alone cannot improve population health. We need all sectors working together: education, labor, transportation. They all work to improve population health. And so if this is recognized in patient-oriented research, then that means we can together work towards better policy integration to improve strengthening of the nursing workforce, which is not just a healthcare issue. It's an education issue. It's a women's empowerment issue. To give a little context of where I'm coming from, the other side of the equator, our country, known as the True North, we have a population of about 40 million. To give some demographic context, like Brazil, much of our population lives in big cities, though big is a relative term compared to Rio de Janeiro. About 80% of our population resides in what we classify anyways as urban areas. And of course, there's no universal definition of what's an urban versus a rural area either. Much of our country's population is concentrated in certain urban areas, and particularly in the southern portions of the countries. So we have vast territories that are sparsely populated and varying degrees of then what might be considered more rural or remote communities. We have a single-payer universal coverage system for essential medical and hospital services. And from what I'm understanding, like Brazil, there's no definition or standard either for what exactly essential medical services mean, but it's a learning process, and we're continually improving along the way in understanding and building evidence on that as well. We have a federal funding mechanism, but the planning and delivery of healthcare services to the general population are done at the level of provinces or territories. 10 provinces along the more southern part of the country, and 3 very sparsely populated northern territories. And so, just like our healthcare system, some say we have 14 healthcare systems, federal, 10 provinces, 3 territories. So the human resources for health data also can be siloed by those different jurisdictions. So much of the, for example, administrative, routinely collected data are housed within provinces, and then some of that information may be collated at a national level, such as through the Canadian Institutes for Health Information. But administrative, routinely collected information is in and of itself a very wide term, and it's only the tip of the iceberg of understanding the nursing and healthcare workforces. So these are some of the different data sources that we've been using, trying to leverage, some of which are explicitly connected to healthcare information and health workforce information, others not, and yet we can use to try to understand not just the healthcare workforce, but where it sits within the broader labor market. So one potential source that, again, we share is having a regular population census, which is a complete enumeration of the population. In the Canadian context, every 5 years, there's also a large-scale mandatory survey as part of the census program, which we lovingly called the long-form questionnaire. And in it, more detailed data are collected on variables that are relevant to health workforce and nursing analyses, including self-reported occupation, which can then be summarized statistically to a national occupational statistical classification, and then mapped to, for example, the international classification of occupations. Advantages is because it's very large scale, our long form is distributed to 25% of all households. That means we often have large samples that allow us to do detailed information on unique occupations. We also have regular labor force surveys, which may collect more detailed labor data, but then the sample size might be a little smaller for doing detailed analyses of nurses specifically or other specific occupations. And like Brazil, also we have many health surveys. Some of these include, for example, the Canadian Community Health Survey based on self-reports, Health Measure Survey, which also collects biomarkers. There are many sources on population health. We don't assume that all of population health data can be collected by one particular source. And similarly, I don't think we do a service in suggesting that all health workforce data can be collected by one particular source either. Each source gives us some information. Some of these health surveys may also include an occupation variable. Whether the size is large enough to tease out nurses and other healthcare occupations will vary, but there are some opportunities to understanding, for example, the health of the healthcare workers themselves. In terms of administrative data, again, that in and of itself is a very wide term. Probably the most commonly used administrative data in the Canadian system is that collected by professional registries, regulatory bodies. So of course, this is then limited to those healthcare professions that are regulated. The criteria, though, for which professions are regulated itself varies in the Canadian context across provinces and territories, and certainly over time. So it's important to understand what are the strengths and limitations. Like in Brazil, regulatory bodies often risk double counting if a particular worker is registered in more than one jurisdiction as well. Another type of administrative data is that collected by governments, in our context, mostly through provincial and territorial governments, such as payroll, employment, entry to practice education programs, and through migration data, internationally educated professionals as well. And then there are an increasing proliferation of ad hoc sources. Investigator-led, for example, researcher-led one-time surveys, often supported financially by a project grant, may be repeated, may not. And that has some of the, I think we have some of those shared challenges in terms of longer term continuity in terms of research projects as well, which tend to be more time bound. And I think that's one of the ongoing challenges, is sustainable research programs over longer periods of time that allow us to build. Professional associations also will often have ad hoc surveys. So there's many that might help us fill some of the gaps that the other more systematic sources are not designed, particularly when it comes to qualitative types of research. So what is the path forward? I believe data linkage is the future. Linking across all of these different sources. And there are opportunities that are unparalleled in the world of data. Such tremendous advances, and some might say bolstered by artificial intelligence. I don't think we need an artificial life form, though, to tell us how to better use these data. There are challenges, particularly if there isn't a common identifier to link, but there are ways that can be developed to help bring these different data sources together. And what is key is collaboration, because all of these different sources are themselves governed by different partners. And so bringing together the partners is crucial, a stepping stone before we can even start to talk about bringing together the data. So I'd like to share with you a few illustrative examples of different projects in the Canadian context where we've brought together not just the data, but the partners as well. So in terms of the data, administrative data collated through the Canadian Institute for Health Information into a central national repository called the Health Workforce Data, it has some advantages. It collects systematically on an annual basis data from the different provinces and territories on regulated health professions and a range of indicators: supply, geographic distribution, basic demographics, education and employment characteristics, but on a selected group of healthcare professionals. And that selection itself varies over time. And the underlying data is what is critical to understand as well, to understand the strengths and limitations, because some of the data might be provided at record level, which then allows the Canadian Institute for Health Information to try to ascertain where we might have double counts across jurisdictions. But some is submitted as aggregate level tables, particularly smaller jurisdictions where privacy protocols are perhaps a bit more stringent because of the small numbers of healthcare providers involved. And so when aggregate data are submitted, then there's no way to tease out those potential double counts. And then what do we mean by nurses? Nurses themselves, a very diverse group of people. In terms of the data that are collated on regulated professions, we have 4 distinct groups: nurse practitioners, who are advanced care practitioners; registered nurses; registered psychiatric nurses, but only in some jurisdictions. Not everywhere across the country is there a distinct education and regulatory profile for psychiatric nurses; and licensed practical nurses, at least in most jurisdictions. In Ontario, they call them registered practical nurses. So the titles, the regulation, the scopes of practice will vary. And then we need to know what are the definitions or the metadata behind these indicators. So for instance, the Canadian Institutes of Health Information makes a distinction between the supply, those who are registered and therefore eligible to practice, which may or may not include some duplicates, and the workforce, that is those who are employed at the time of their registration renewal. And then there are those whose main job duties involve direct care to clients. And then there are those who also might be contributing mostly in other essential job aspects of nurses, such as educating the next generation of nurses, or primarily conducting research on nurses and nursing care. All critically important pieces of the nursing workforce. One of the challenges or limitations of not having national unique identifiers for healthcare providers in Canada is that means that outflow or exits from the nursing workforce can only be measured within a province or territory and not at a national level. So some basic trends: what does our nursing workforce look like, and particularly what can the data tell us and what can they not tell us? So for one, if the registered nursing workforce is the largest component, nurse practitioners, advanced care nurses are smaller in number, but growing, not just in numbers, but in importance in terms of meeting primary health care needs as independent practitioners across many provinces as we struggle with the common challenges of health workforce needs, increasing needs to meet the population demands. Registered psychiatric nurses, small numbers, but are not, as I mentioned, they're not independently regulated in all jurisdictions. So it's only a small portion of the country that have data on this group. And then licensed practical nurses. And we see in 2020, oh, something happened in 2020. Oh yeah, a pandemic hit us. And the numbers of registered nurses increased rather rapidly, as well as licensed practical nurses, because many heeded the call, please come back and help, many who were retired. And so there was a jump in the numbers, not necessarily because there was an increase in capacity, but because many previously retired nurses came back and registered. So we still don't know what are the longer term implications in supply of the nursing workforces as we move into a post-pandemic period. And what do we know also? Well, they may be registered, but from about 90% are actually employed at the time that they submit their annual registration renewal. So a fair amount are not necessarily working in the nursing profession, but maintain their registration. So that's an important capacity component that we need to understand when we're talking about the stock of the nursing workforce. But how many are providing services in nursing? And how many are providing direct care? And even that definition of what does direct care mean may vary. In some situations may involve, for example, public health, but not in others. So the very definition of what do we mean by direct care is important to understand as well. And particularly, given the diversity, registered psychiatric nurses in particular have a much lower level of retention in terms of providing direct patient care in relation to those who are registered. A very different profile than the other categories of nurses. Amongst those who are providing direct care, we see some considerable variations across the different provinces and territories in terms of their density or numbers per 100,000 population. But if we look closely, just at 1 year, the latest 2022, we also see some gaps. So for example, some jurisdictions might not have the latest update of their data at the time that the national agency calls them and say, hey, it's time to submit your data. And so that field might be blank. And yet the national report will issue a number as if this represents the whole country. Particularly about the Canadian context as well, listed on the table, we start with first the 10 provinces, and then the last two series of data are for the territories, which are remote, sparsely populated, and yet seemingly have very higher densities of health care workers, nursing workers than heavily urbanized parts of the country, which intuitively doesn't sound like what we would expect. But then digging into the underlying way these data are collected is that many of the registered nurses in the territories don't live there full time. They come and do 2-3 week rotations, or they provide services by telecare and video, and yet they remain registered. So supply, worker, direct patient care in and of itself doesn't give us the whole picture of what's happening and what's available to meet population needs. And that's also something we have to work towards, harmonizing what do we mean when we're talking about numbers of nurses. It sounds like it's a simple question. How many nurses are there? But it's not. And some of the data that we also looked at, for example, that's collated by the Canadian Institutes of Health Information, is that gender distribution. And those registered psychiatric nurses, which we already saw had lower retention, they're also have the highest proportion of males in the profession. Is there a correlation there? Further studies definitely needed. Another illustrative example that I would like to share with you is how we've been using population census data. So we used, for example, the long form, so a 25% sample of the entire population living in private households. And we teased out those who self-reported their occupation in nursing. And already right here, we're seeing a little bit of a divergence from the administrative data because the occupation classification includes under nursing professionals, nurse supervisors, registered nurses, and registered psychiatric nurses. But nurse practitioners are grouped with other advanced care providers and so aren't readily teasable into a nursing classification itself. So, and as well, those who are primarily based in an academic or research environment are grouped with other researchers. So already we're seeing sometimes the data aren't as easy to compare across sources as we originally hoped. So, and that's okay. There's no perfect data source. But each source will give us some information. So we looked at, for instance, from a labor market perspective, what do we know tend to be the drivers of disparities in wages? The traditional human capital variables, age, education, place of work, gender being our particular key variable of interest, and some of those intersecting social identity variables, such as having children, being married, being a migrant. In the Canadian context of employment equity, what's known as visible minority status, or Indigenous ancestry, self-reported. We looked at wages, which an advantage to the link is that rather than based on self-reports, the Canadian Census now captures objective income data and wage data through linked income tax and benefits records. So very high quality data, about a 97% matching between the census respondents and their income tax records. And we looked at, in the context where urban and rural is more complex than just you live in a city or you don't, we looked at a continuous index of relative accessibility, population density, and infrastructure, known as the index of remoteness for all inhabited communities in the country. And we conducted some multivariate statistical modeling, including the Blinder-Haka decomposition analysis for the gender wage gap. So what did we look at? We looked at many of those gaps identified from the World Health Organization in terms of leadership. So in the Canadian context, a bit more than half of senior managers in health and social care are women. On the surface, it sounds good. We have gender parity in numbers. But in a field where women dominate, about 80% of all healthcare workers are women. In Canada, about 75%, for example, of health policy researchers in health are women. 90% of nurses are women. These are the people who are feeding the pipeline to leadership positions. So is numerical parity enough to say we have true gender equity in opportunities for leadership? I can't say I have an answer to that. But I would like to engage with you, with researchers, with leaders, policymakers in that conversation. And to have the evidence to support that conversation is what makes those conversations then become so much more meaningful. I would argue there are still persistent career barriers that disproportionately affect women. Not saying necessarily 80%, 90% of health leaders should be women, but something is going on here. Something in that ladder isn't quite a straight line for women. Another challenge is not just gender equity in the healthcare workforce, but does the health sector itself have the capacity to attract and retain talent? We look not just at healthcare workers, but at a group, 12 groups actually, of health workers, education workers, and other STEM professionals, scientific, technical, engineering, and mathematics. And we found not just nursing has the highest proportion of women and they have lower salaries, even controlling for having a university education, having post-secondary, postgraduate education, controlling for all of those various known drivers of wage differences. But across occupations, the greater the proportion of women in that occupation, the faster the average wages fall. And you know what? They fall faster among men than they do among women. So a take-home message is we need in the healthcare system to address gender inequality because it itself hinders the ability of the healthcare sector to attract and retain talent, not just women, but men as well. And so we're all in this together. We also looked at geographic imbalances. So this is a particularly policy-relevant question. I've yet to see the golden answer for attracting more numbers of healthcare providers to rural and remote communities. But the policy dialogue in this area, ironically, often does focus on, well, let's pay them more. Let's give a financial reward to work in rural communities. Kind of dialogue you don't hear so much when it comes to gender. Let's pay women more? You don't hear that so much. At least I don't. But ironically, we found, and we've done this a couple of times now with different data sources, there's very little actual evidence that rural healthcare workers experience pay disparities in relation to their urban counterparts. Nursing in particular, actually in the Canadian context, are the most equally geographically distributed occupation in terms of relative rurality of communities compared to physicians, dentists, the ones who the politicians tend to focus a bit more on in terms of the geographic distribution, the male-dominated professions. Nursing, a little more geographically equal. Nursing, as the lower of the two charts show, no consistent pattern in terms of where nurses practice and their relative income. A little bit all over the place. So no clear trend, for example, that financial incentives alone will help redress rural health inequalities. But what we don't hear as much is true gender equity in pay. Nursing, like every other healthcare occupation we've looked at, all else being equal, Men earn more on average than women. In the Canadian context, we found that women earned about 5% less than their male nurse counterparts after controlling for all of those different variables. The gap is a little less than specialist physicians and some other higher remunerated occupations where there's more room for a greater gap as well, and where there tend to be a bit more self-employed workers as well. So we know the gap is not yet eliminated. Illustrative example I would like to share with you also is within one jurisdiction. So as many of our administrative sources are themselves housed and governed within jurisdictions, so I'd like to share one example from my own province of New Brunswick on the Canadian East Coast. We're a small but amazing little province, and we have some wonderful dynamics of collaborative research between the provincial government and the academic setting as well. And so we have co-developed questions between the government decision makers and the academic community, and undertaken this research at the New Brunswick Institute of Research, Data and Training, which is a university-based secure computing environment that is mandated to house administrative data that has been de-identified but record level and linkable, so that we can start breaking down those silos and bringing multiple pieces of information together that haven't otherwise been able to do before. It's not an easy process. The partnerships, years in the making. Years to get laws in place that developed the platform and guaranteed researcher accessibility to the data sources. It involves human trust and relationship building. So when people talk about artificial intelligence, I usually pause, because I think it's the personal relationships and the partnerships that matter the most in bringing research to life. The research project in particular that was prioritized by our provincial government was linking the individual level payroll on nurses in the publicly funded hospital system to graduates of nursing programs at the college and university level, to help answer the policy questions of, well, how many of our nursing graduates stay in our jurisdiction? How many live and work as nurses in hospitals in New Brunswick? What affects a nurse's decision to stay, to retain being employed, providing direct patient care in the hospital system, versus retiring or moving into a different profession? And among those who do stay, among those, who do exit the hospital system, well, do they stay in the province or do they leave altogether? I believe these are also questions that we share. To answer these at the individual level, in the absence of a common identifier, a probabilistic matching was done based on the name, the date of birth, and the gender of each individual. So the payroll data, including all hiring and termination records, were linked through the common registry of all citizens who are eligible for public health insurance in the province. Based on that matching, about 98% of full-time nurses, a little less, about 88% of part-time and casual nurses were able to be linked then to the resident registry, so that we would have their geographic information, their age and sex, basic demographic data. The graduate data also from the schools of nursing at the university level and licensed practical nurses at the community college level were linked. About 77% of university graduates were linked to the demographic data in the citizen data set. More for college graduates. One issue that might affect the quality of of the matching process is that the community college graduates tend to be a bit more local, New Brunswick students, whereas university students may be more likely to include international students. And it was only partway through our period of observation in 2017 that international students became eligible, considered deemed eligible for the public health insurance system. Before they were required to have private healthcare insurance. And so that number of matching is increasing, not necessarily due to a change in data quality, but due to changes in the underlying eligibility criteria as well. And some who aren't matched maybe because they didn't change from, if they only came to New Brunswick to study, they might have retained their insurance in their home province. So not knowing who's matched doesn't necessarily mean a person came and left, but it could be the way that the data are capturing those individuals. We're quite excited by how strong the linkages have been and enable us to answer these kinds of questions that weren't really able to answer before. I can't actually present results to you right now. Part of the partnership agreement as well is our government colleagues get to take the first peek. So they're still looking at the data, trying to understand it, understand what are the policy drivers, and as soon as that information, the actual results become available, then I can send it to your esteemed director who can share that with you as well. But I hope this process of how we can better use data itself piques some interest in opportunities that I know many of these data sources we share, the pain as well as the love for the data. So what are some of the lessons learned in measuring the nurse employment transitions? Well, one is data access transparency, strengthening social institutions, one of the Sustainable Development Goals. That means many things, and one of the areas of increasing data transparency while protecting privacy of personal information in our context was the establishment of the Act Respecting Research. Many years in the making, but gave a mandate, a publicly transparent mandate to the university-based Institute for Research Data and Training to house these confidential data and allow them to be used and accessed under secure conditions with purpose-built project mandates to investigate policy actionable questions. At this stage, the research is focusing on those graduating from the public sector, university and colleges within the province and working in the public hospital system. Further down the road, because the payroll systems are themselves siloed, it is hoped that this work will extend to those working in community clinics, residential care facilities for seniors, and other types of facilities as well. Because one limitation is that the data only record the most recent nursing qualifications. So for example, if a nurse accessed one of the bridging programs, if a licensed practical nurse accessed a bridging program to become a registered nurse, they would be recorded only as a registered nurse throughout the analyses going forward. And sometimes data structures change. I know I've seen that in some of your Brazilian data sources as well. While payroll had more time trend data on those who entered the public hospital system, when people left, termination records weren't being collated electronically as recently. So nurses who might have left before 2016 would not have been captured in this analysis. And as well as I mentioned, if they're no longer registered in the public health insurance system, that may be due to factors not necessarily related to their practice as a nurse, but related to the nature of who is captured in public health insurance known as New Brunswick Medicare. The data allow us to answer some questions, not so much others. So for example, the demographics are rather limited. We have age, sex, and in the context of our French-English bilingual province, preferred language. Very little data on other types of social characteristics such as ethnic or indigenous ancestry in these data. But I don't think the goal is to ask everybody every time they change jobs, what is your ethnic or indigenous ancestry either. So linking the data becomes a way to be able to bring those different informations, collect once, reuse multiple times. As a fourth illustrative example then, if we do want to enhance some of these questions, for example, in terms of equity, diversity, and inclusion, in terms of better understanding attrition and retention issues. We're working simultaneously as well with multiple partners across the country through the Canadian Health Workforce Network to try to not just raise awareness, but practical steps to build capacity to have a common set of data elements adopted by regulatory agencies for different regulated and also professional associations for non-regulated healthcare professions across the country. Again, a multi-year process of building the relationships, building the trust, building standards for the future. And lastly, the fifth illustrative example that I would like to share for you is, well, what about tomorrow? What about the next generation of nursing and healthcare researchers? So one partnership that I would like to mention, perhaps evoke some inspirations, is a multi-institutional and multi-sectoral partnership known as the Consortium for Analytics in Data-Driven Decision-Making. And the acronym becomes CANDI3. So that was a fun acronym. Led out by Amélie Casnel-Lavallée at Université McGill, this collaborative work brings together 18 universities across Canada, but also internationally, Florida State and Max Planck in Germany, bringing together graduate students from different partner institutions, from different disciplines, after finishing regular coursework in their own academic field, for regular exchanges and upskilling in the policy relevant skills of today and tomorrow that we tend not to learn so much in the pure academic knowledge-based studies. Preparing infographics, data visualizations, writing policy briefs, communicating with policymakers. This is a regular experiential learning training program with regular both workshops specifically for the students and opportunities for multidisciplinary exchange between academic and policy and private sector data intensive organizations as well. Many of the students do work placements, for instance, in government or in the private sector, and develop those skills in communicating data, research, and evidence to help transform the knowledge into policy decisions. Oftentimes we may be talking about the same thing, but speaking a different language. And so what do the researchers of tomorrow need? And not just the researchers, not all of our graduate students will necessarily go on to a research-intensive occupation. They're also the policymakers of tomorrow. And so bridging together from the graduate study stage is one vision of tomorrow. So I'd like to end with some key questions, not necessarily ones derived through policy, but ones that I hope we can all engage with together, not just in terms of research, but our own reflections as consumers of healthcare, which we all are as well. So what, for example, tells us that we have room to improve equity in the nursing workforce? How do we know? When we start asking ourselves, how do we know, then we start imagining potential uses of data. What are some of the lingering impacts of the COVID pandemic affecting the stock and flows of nursing workforce? So we've started to see some blips, but we don't yet know what the longer term implications of that are. We know there will be pandemics in the future as well. So are we capitalizing now to take advantage of the knowledge and lesson learned to be better prepared for the future? What do we also know from the evidence? That reduced wages, devaluing women's work affects not just women, but also men as well. And so how do we ensure the ongoing competitiveness of nurses, of the nursing workforce, to attract and retain talent? And that means attracting men to nursing as much as attracting women to nursing. And not just that, but how do we know when we've got it right? Sharing examples, successes, is as important, and yet somehow doesn't seem to get translated and shared in the same way as the studies do. I think we need more mechanisms to share lessons learned as much as we do to share evidence. And my third key takeaway theme would be, we can't just rely on the status quo. Doing the same thing over and over will not yield better performance. We know this. But how do we shift discourse, particularly when it comes to wage disparities from equal pay for equal work? It's been decades since the International Labour Organization started producing policy frameworks around the notion of equal pay for equal work. And yet the gender wage gap still persists. So how do we shift the dialogue from equal pay to equal work to equal pay for work of comparable value? And that's where the work of nurses becomes so critically important to understand and to value. And at a personal level, what's one thing I can do to make a positive impact for gender equity in my own organization? Health is a reflection of society at large. Healthcare workers don't work in a vacuum, and they're not a product of a vacuum. They're a product of society. So whether you're in the nursing workforce, a nursing researcher, or not, what's one thing I can do to improve gender equity where I work? And so I'd like to thank you for indulging me. I would like to acknowledge some of the various partners as well, that I've shared some stories from the Canadian context that I hope you might find meaningful in your own. And I'd like to end with some words from our own chief statistician, Anil Arora, who said, "Data is a team sport." And I know some people in the room like their team sports. Collaboration, bringing people together, breaking down silos, but recognizing that there's no one player who can win the game. There's no one data source that can win over the knowledge base either. So thank you very much.
Oh, thank you, Gulin. Sorry, Niro. Gulin was the other colleague working in Geneva, so sometimes I mix the names. Thank you, Niro, for the nice chat and presentation. I have a seat. I can leave there. Well, vamos ver se tem alguma questão aqui no auditório. E as pessoas que estão no YouTube podem enviar um comentário, uma pergunta Ana Paula, que vai nos ajudar se a gente tiver enfim, algum comentário, alguma questão. Eu queria, talvez só para começar um pouco, né? Primeiro, assim, com um comentário sobre esse mecanismo,
About
né,
this
muito
very interesting mechanism, and it's used for research groups to create a consortium that can link and articulate research institutions and researchers. Many times in our projects, we have more than 20 researchers from 15, 20 different places. And the project ends, and it's a huge effort to get everybody collected together. So I think it's a smart way. It also has a very friendly name and associated to Canada. I'm sorry, I'm speaking in Portuguese. I'm going to speak in Portuguese, and then if necessary, I'll speak in English. So one interesting thing that we can discuss, I still have a couple days we can discuss with her the experience. Uma coisa que foi interessante para mim é que essa pesquisa
looking for is the linkage. I think, well, she said this is the future, and I may have comments from here, or I'll ask further comments from Niro. Bom, eu convido aí todos.
I invite
alguém queira.
all of you, if you comment, ask a question, even in Portuguese, we can translate. There is simultaneous translation and comments from the YouTube. Fabiano, please.
Tá ligado? Não. Acho que está desligado. Fala daqui, Fabiano. Tá bem. Ok. Fala aqui? Fala aqui. Só ligar. Fácil.
Hello. I like very much the Isso é comigo? Hello. I like very much the important and fundamental comment of Nehru. You can take the better machine, the better intelligent technique, but you not have data, you not go anywhere. It's very, very important. No data, no mining. To data mining is needed data. Thank you. Também tá desligado.
I would even go. I would go one step further and say no people, no data, no mining. And I think in this era of excitement around artificial intelligence, that message that it takes collaboration and partnerships risks sometimes getting hidden under the shiny new toys.
That's it. Décio, please, come here. Yeah. Liga isso aqui, vê se está.
Neru.
Ok.
Viu, Fabiano? Para mim funciona. É contigo. É com você especificamente. Neru, I saw that I saw that there is an act of your university about data. I would like to know more about the Canadian legislation about data and the restrictions, because here in Brazil, our legislation about that is a young legislation, and the people doesn't sure about what to do with it. I would like to hear about your experience.
Thank you for the question. So first, I would like to stress that there's no one model that works anywhere in Canada. We have our model in our province. Other provinces have other models. Being a little bit, our institute followed on the heels of some other larger provinces as well. So we learned some lessons from those. And one of the reasons that there was a push in our province to have legislation is to facilitate going forward that other projects then wouldn't necessarily face the same hurdles. So for example, in provinces where there isn't an underlying research legislation, we often hear that researchers have to go through the same process over and over and over to be able to use the same data sets if their question changes. Because data minimums to respond to a particular question is one of the fundamental drivers of privacy. So and this was not something that happened overnight. It was many years in the making, years before I even moved to New Brunswick, so I don't have all of the historical knowledge, but it was absolutely based on relationships and trust between government and between academic researchers and between the custodians of the original data sets, that we could demonstrate that we can use de-identified data and maintain principles of privacy and use the data responsibly to ask questions, answer questions that are policy relevant. And that is a long-term relationship building. So what the Act does is it allows the university-based Institute for Research Data and Training to have a mandate to accept government administrative data at a de-identified level. We have two campuses. There are two different locations where the facilities themselves are secured. No internet access, your phone is confiscated when you enter the room, etc. And the data themselves, we don't, aside from particular government projects like this one that I mentioned where we have names to be able to do the original linkages, most of the time we get a de-identified version with a scrambled identifier that allows the linkage in the research environment, but then doesn't allow identifying any particular individual. So there's some precursors to that as well, one of which is the legal standard that accessing healthcare services in and of themselves implies consent at the patient level that their data are then used for research. And that itself isn't necessarily standardized across jurisdictions either. So there are other kinds of data that have been, projects that have been blocked by privacy commissioners saying that in and of itself is not sufficient. So this is partly also what the law then protects, is what does informed consent to use the data mean? And then it's very particular on what kinds of data. So those that are using publicly funded healthcare. So that doesn't necessarily mean then that all data can be connected and linked to it. So there are some surveys, such as the Canadian Community Health Survey, which is run by the federal agency, that includes questions explicitly asking for informed consent. Do you agree to allow your data to be shared with the provincial health ministry for the purposes of linking to administrative data? And the consent rate for that is about 90%. So each step along the way has its own particularities as well. Other provinces may have an institute that houses provincial administrative data without a overarching law behind it. Some provinces now, there are also federal Statistics Canada Research Data Institute. So at our university, the Provincial Administrative Data Center is in one secure computing environment, and then you walk across the hall, and there you can access Federal Statistics Canada de-identified census and survey data sets. Some provinces now are moving in that direction, giving the right to use the administrative data through the federal infrastructure. So it works a little differently, depending on oftentimes the relationships behind it that help steer whether the model will work better in our context this way or that way.
Well, thank you, Niro. There's it may change, but compared to Brazil, in the past, Canada had the most restricted norms in terms of using data census. Brazil used to disseminate the microdata. Canada was not the case, so you had to go there inside a protected room, all the restriction that she mentioned. And it was funny because here you could buy the CD with the microdata that was anonymized, and was well, that's funny, but the comparison was a bit strange to us, and we had to, well, Niro was part of the group that made the first use of census data to analyze the health workforce, and we had so different situations in countries. So in Canada, we had to ask them to do the to do the analysis. We send the questions and anyway, what we would like to know. And here you had the CD, just we put in the computer and run the analysis. Remember that? So it was a bit. Anyway, there is an institute in Minnesota who puts together, for historical reasons, all the census around the world. You can access it through the internet, iPhones. I recommend the ones who would like to or need to use the data from census. And they, well, there you only can access the data in a very special room with no phone and nothing electronically, only a piece of paper or actually nothing. You just go there and you print your tables. Yeah, that's it. Okay. No further questions. We can. Não tem nenhum comentário? Tem? Não? Tem? Não? Daqui. Traz para cá. Fala você, Ana Paula.
Jonas Sami, da Universidade
Jonas Sam from the Federal University of Rio Grande do Norte. He congratulates and thanks the speaker, and he makes a comment that one of the issues in Brazil that is not clear is how to face the gender inequity by the nursing, like protocols for moving one shift from the other, only women Jonas é da Universidade do Rio Grande do Norte.
And researchers. And he said one of the questions in Brazil is the inequality in terms of gender for nurses, among nurses. I said that you do have issues in the moment that they call, how can I translate this, to transfer the work from one shift of a night shift to the other day, and there are issues in relation to the gender. I guess he's talking about where in the work there are discrimination and inequality in terms of how female nurses are treated and in relation to the male nurses.
So I think part of what I often see as a challenge in advancing empowerment of women in nursing is not as strong of a research infrastructure on nursing itself in relation to many other categories of healthcare workers, particularly physicians or dentistry personnel. So I'm not saying that I have an answer in terms of how do we dismantle some of these inequities based on gender that manifest in so many different ways. But critically, I think we need to empower nursing researchers. We need to have a stronger funding mechanisms, empowering and upskilling the next generation of nurses as researchers themselves to bring the evidence to the table, to bring nurses to the health workforce table, and not just think of nursing as the caring profession, but as the skilled profession. And starting to empower nurses in research is critical to empowering nurses as practitioners.
Mais uma? Diga, Ana Paula.
Ele fala sobre o desalento com a profissão.
The data for people who leave the nursing workforce for another occupation, how is this impact the Canadian workforce? Eu acho que uma questão aqui, não só aqui, mas em todos os lugares, é que as enfermeiras estão saindo da profissão por causa de burnout e não estão se sentindo confortáveis. Não estão.
Work. So this is an issue in Brazil. He asked about if the Canada you have any data or you can share.
So I think this is a challenge that has shocked many people, how quickly nurses went from being the heroes early in the pandemic to being the recipients of animosity, even violence in the healthcare system. I don't think it's unique to any one particular country, and I think it's been particularly shocking to many people how fast that hero dialogue or public perception of nurses as heroes has shifted. And it's an uphill battle. Many countries now are facing, not just facing, I think most of us knew there were challenges in the health workforce, but they seem to be more deeply entrenched now in ways. Now, on the one hand, and I think this gives us an opportunity then, like, I'm not sure in Brazil, but in Canada, our research funding landscape for the health workforce up until now has been abysmal. Less than 10% of health research funding has gone into health systems research in the past few years, and as my colleague at the Canadian Health Workforce Network calculated, of that, less than 5% goes to health workforce research. And yet, health workers are one of the largest budget lines. So I think, again, building that evidence base, moving beyond the anecdotes into systematic recordings of how attrition of nurses, money talks, how it hits the healthcare system financially, can be a powerful policy lever among decision makers that we need to do better to retain nurses.
Okay. I take this opportunity to thank you very much, Nero. Well, it has been we had a wonderful time working together. Was a data and information team, and I think we'll end up establishing a nice friendship, even bothering her daughter sometimes, Samira, in Geneva, and I'm glad that we kept this connection. And well, since yesterday, you already started to make a contribution to the project. I'm not going to describe here the discussion that we had yesterday, and then we'll be here in the next few days, discussing with the team and the other researchers in the house. And on Friday morning, Neil will be in the School of Nursing here in the university, discussing with the group there, see if there's any room for long-term collaboration between the two institutions. And thank you. I think it was a wonderful session. Thank you very much. Thank you for the ones that are here. And thank you for the translator and the group translators, sorry, and the group who helped to make the transmission through YouTube. Thank you. Obrigado.